Hello, everyone, and welcome to our webinar. This is a webinar from Radcliffe Vascular, and today we will learn all about the combined problems of deep and superficial disease, venous disease. When should we treat it? When should we maybe not treat both? There's all these questions that maybe you have, and hopefully at the end they will be answered, but also remember that please do ask your questions and then we can answer them. If there's still a lot of questions left. My name is Josee van Rijn. I'm a vascular surgeon from the Erasmus Medical Center in Rotterdam, in the Netherlands. And I have a fantastic faculty today. It's an all-female faculty. I'm very proud of this. So first, I'm joined by Dr. Erin Murphy, and she's a vascular surgeon in Jackson, Mississippi. Hi, Erin. Welcome. And then we have Dr. Emma Wilton, and she's a vascular surgeon at the Oxford University in the UK. Hi, Emma.
Hi.
I'd like to tell everyone again that this will going to be an interactive webinar. We will have 3 presentations, and you can send in all your questions during all the presentations, but we will answer them at the end, so we don't interrupt anyone while they present. But please do send in the questions that you have. So let's start. I would like to hand over to you, Dr. Wilton, and you are going to discuss about all the types of interventions that are possible for both the deep and superficial venous system.
Thank you. So thank you very much. So yes, we're going to talk about types of superficial and deep venous disease and their treatment options. So obviously the reason we're trying to treat these patients is to prevent complications of chronic venous disease due to acute and chronic superficial and deep venous disease. And in the worst case, this is to prevent ulcer formation. So venous disease can be categorized into both acute and chronic presentations, and we'll just cover these in the talk today. So looking at acute superficial venous disease, there can be superficial vein thrombosis, which can be limited to varicose tributaries or affect a saphenous trunk. It can be complicated by extension into the deep venous system with concomitant DVT and PE. And I've just put a picture here of the ESVS guidelines of how to treat this. And of note, if you have a superficial vein thrombosis within 3 centimeters of the junction with the deep veins, then therapeutic anticoagulation is recommended. Hemorrhage is also another acute presentation of superficial venous disease caused by venous hypertension from untreated varicose veins, potentially iliac outflow obstruction, and even right cardiac failure. The treatment is obviously leg elevation and external pressure, treat the underlying venous incompetence, but potentially also local foam sclerotherapy to prevent recurrent bleeding. Acute DVT is the acute presentation for the deep venous system, and the annual incidence of this is about 1 in 1,000 people per year. The main complication of this is post-thrombotic syndrome, and about 30 to 50% of patients with an iliofemoral DVT will go on to develop some form of post-thrombotic syndrome. And in 10% of these cases, the incidence will be severe post-thrombotic syndrome, which has a significant impact on patients' quality of life. This is often quite a young patient cohort, and so can be quite disabling for them. The mainstay of treatment is obviously anticoagulation. However, we do have endovascular treatment options now, with the main aim being at early restoration of vein patency, giving immediate symptom relief to these patients. It also allows us to preserve valvular function, giving long-term benefits, and being able to treat significant underlying stenosis, maintaining long-term venous and stem patency, and reducing the risk of severe post-thrombotic syndrome. The interventional treatment for an acute DVT is thrombus removal, and there are various different ways that that can be done, with stenting of the underlying venous system. And this picture just shows some clot that was removed in an acute case of DVT, as well as some pictures showing venograms with an acute clot, the thrombectomy, and then the final venogram showing resolution. So moving on to chronic venous disease. Again, I've just put an overview here from the ESVS guidelines with how to investigate patients presenting with chronic venous disease, both below and above the inguinal ligament. So there are obviously standard treatments that can be employed in these type of patients, including advising exercise, compression therapy, and in some cases, venoactive drugs, and then operative intervention. So for superficial venous incompetence, the standard investigation is with a duplex ultrasound. This helps us to delineate the venous anatomy, and it also allows us to categorize valvular incompetence and reflux within the veins. So retrograde blood flow with a duration of more than 1 second is pathological in the deep system, whereas retrograde blood flow with a duration of more than 0.5 seconds is pathological in both superficial and perforated veins. We can also find obstruction on the duplex scan, venous obstruction. The CAP classification of venous disease is also helpful for us to clearly categorize the severity of the disease that we're dealing with. So varicose veins or superficial venous incompetence are abnormally dilated, elongated, tortuous veins measuring more than 3 millimeters in diameter. They occur in approximately 10 to 30% of the general population. Approximately 80% of them occur in the great saphenous vein only, with approximately 15% occurring in both the great and the small saphenous vein. So primary varicose veins are mainly due to faulty valves in the superficial vein. So this may be at the saphenofemoral junction, perforating veins, or indeed the saphenopopliteal junction. This diagram just demonstrates that. It's also possible to get secondary varicose veins from damage to the deep venous system, for example, in following an acute DVT, or from increased pelvic pressure or trauma to the lower extremity. And I've just shown here how that can be, how that can happen from both deep and causing deep venous reflux or thrombosis. So the patterns of reflux, the patterns of reflux in chronic venous incompetence occur approximately in 70% of the superficial veins only, 20% in a combination of both superficial and deep venous incompetence, and approximately 10% in just the deep veins. So the treatment of superficial venous incompetence, they can be treated in the presence of segmental deep venous reflux. We need to investigate the deep venous system for outflow obstruction in patients with advanced chronic venous disease and superficial venous incompetence. And if venous outflow obstruction does exist, then we can potentially treat both venous outflow obstruction with stenting and superficial venous incompetence sequentially. And I know Erin's going to talk about that, I think, later. So intervention for superficial venous incompetence, again, I've taken these from the ESVS guidelines. So patients with great saphenous vein incompetence requiring treatment, the suggestion is that these patients should be treated with endovenous thermal ablation as the first choice of treatment. Again, patients requiring treatment with superficial venous incompetence, cyanoacrylate adhesive closure can be considered, as can foam sclerotherapy, particularly for saphenous trunks with a diameter of less than 6 millimeters in diameter. For patients with superficial venous incompetence, mechanico-chemical ablation may be considered when a non-thermal, non-tumescent technique is preferred. And again, we mustn't forget that surgery with high ligation or stripping can be considered if an endovenous thermal ablation option is not available. And again, patients requiring treatment for varicose tributaries, ambulatory phlebectomy, or ultrasound-guided foam sclerotherapy, or indeed a combination of both, should be considered. And endovenous, for patients with chronic venous disease requiring treatment of incompetent perforating veins, again, endovenous ablation or ligation can be considered. For the small saphenous vein, endovenous thermal ablation is recommended as opposed to surgery or ultrasound-guided foam. And those with anterior accessory saphenous veins that are incompetent requiring treatment, again, endovenous thermal ablation should be considered. And incompetent saphenous trunk treated with endovenous thermal or non-thermal ablation, concomitant tributary treatment should be considered as part of the shared decision-making process. And finally, patients with advanced skin changes, so CAP for up to 6, with isolated or residual incompetent perforating veins thought to be significant, treatment of these should be considered. So when we're talking about endovenous treatment, what we're talking about is thermal ablation or non-thermal ablation techniques. Thermal ablation is radiofrequency ablation or laser ablation, so endovenous laser ablation. And I've put a picture at the top of the screen of a radiofrequency catheter in someone's great saphenous vein. The non-thermal ablation techniques, of which there are various, include ultrasound-guided foam sclerotherapy. In the picture at the bottom left shows foam being delivered into a venous tributary. Cyanacrylate glue can also be used, as can mechanicochemical ablation with devices such as the Claravane. So moving on to more chronic venous outflow obstruction. This again can be either thrombotic or non-thrombotic in nature, the most common being post-thrombotic syndrome following an acute DVT. As mentioned previously, the incidence of this is up to 50% in those patients with an iliofemoral DVT. And as mentioned previously, up to 10% of those patients will go on to develop severe post-thrombotic syndrome with venous ulceration over a 10-year period. Non-thrombotic causes can be things such as congenital lesions, Maytherner's or Nivel lesions, or indeed external compression from fibroid uterus, etc., as well as malignant causes. So this can be treated potentially with iliac vein stenting. This is a minimally invasive procedure, and it relieves the venous outflow obstruction, improving symptoms in patients. The main symptoms it improves is pain, swelling, and aids ulcer healing. It's really important, however, that we do select the right patients to treat, and these patients need to have chronic venous disease due to venous outflow obstruction of at least moderate to severe nature and a CAP score of at least C3. Inflow is absolutely crucial to maintaining stent patency, and therefore inflow needs to be good or at least adequate, and the patients need to be anticoagulated, as they will require this following placement of a stent. Deep venous incompetence. The mainstay of treatment currently is with non-operative management with compression garments or compression bandaging if an ulcer is present. There are experimental venous valves reconstruction with either open surgery or endovascular techniques at present. However, these are not in mainstay of treatment at the moment. So in summary, the aim of treatment of the deep and superficial venous systems is to treat venous hypertension with the importance of reducing symptoms and preventing venous leg ulceration. Superficial venous incompetence, the treatment does depend entirely on symptoms and indeed individual patient factors. Endovenous intervention is the #1 treatment option, of which thermal ablation would be the preferred option in most cases. Treatment of DVT should be carried out if possible in the acute phase to reduce valvular damage, preserve inflow, and reduce the risk of needing extensive stenting in the future. One should have a high index of suspicion for venous outflow obstruction when seeing patients in clinic, and really listen to their clinical history and venous duplex findings to determine whether or not further investigation for venous outflow obstruction needs to be carried out and potentially treated. And deep venous incompetence, as I mentioned, the mainstay of treatment at the moment remains with compression therapy. Thank you.
Thank you. Thank you so much, Dr. Wilton. That was a wonderful presentation and very comprehensive review of all the possible treatment modalities we have for both the deep and superficial system. I like to remind everyone that there is a Q&A section at the end, so please send in all your questions. And so we're not going to answer them immediately, because I see there's already been questions been sending in, which I like a lot. Don't think you are being ignored, but we have the session completely at the end. So I will take over, and I will give a presentation on when not to touch the superficial system, when there's also a problem in the deep system, some strategy, advice and guidelines. So I'd like to start off with a case. And it is a patient that was sent to our hospital a couple of months ago. And the referring question was, does she have pelvic venous disease? And if so, could you then please treat that? Because the center that she was referred from does not do any pelvic venous interventions. I asked the patient, what is your problem? And she said her main complaint is that I have pain in my leg, more so on the left side than on the right side. I have cramps and I have a swollen leg, specifically when I have been standing for the whole day. I have an ulcer at my ankle on the left side, and it has been there for over a year, and it doesn't seem to close. It's very painful. And I have varicose veins on both legs. And I also seem to notice that there is a visible vein that is starting to develop above my pubic bone, which was never there before. And with that, she also said I have abdominal pain, which was influenced by her menstrual cycle. In her previous history, she had a DVT 3 times on the left side and multiple pregnancies, and she also has atrial fibrillation, for which she uses rivaroxaban and bisoprolol. And the rivaroxaban, of course, was also for all her DVTs. When I looked at her legs, I found that specifically her left leg was more swollen than the right leg, both the upper and lower leg. She has a lot of varicose veins on both sides, and there is a big vein in the groin region above the pubic bone. She has an ulcer on the medial part of her left ankle with hyperpigmentation, corona phlegmatica, and atrophy blanche. You can see her foot in this picture. So I'm trying to make a differential diagnosis. There is, of course, a lot, but specifically for venous, I think, she probably has post-thrombotic syndrome, but she might also have pelvic venous disease because she has this abdominal pain and it's more around her menstrual cycle, which can be secondary. So because she has the pregnancies, but it can also be collaterals from maybe a post-thrombotic obstruction. They can be primary insufficient or maybe a compression from May Turner or a nutcracker. And she can have primary or secondary varicose veins in her leg. So this is going through my mind, and I do the duplex ultrasound. And this is also always a drawing that I make. And I don't think you see my a pointer, but what you can see is that there is a lot of trabeculation, so scarring of her deep system, her femoral vein, her popliteal vein, her common femoral vein, and it goes all the way up to her iliac veins. And I see a very big GSV, and that is not refluxing. It's just there's actually sort of like continuous flow, and it's a lot bigger than it is on her other leg. And I see a palmar vein that is draining blood from the left to the right groin. And here you can see the ultrasound of the GSV, and it was almost 7 millimeters. Now, it's always important to have a very close look at the abdominal veins when you do duplex ultrasound, specifically because a lot of the times there is this duplex ultrasound that's coming back and it says, well, it's open. It can still be open, but it's not only about is it open, is there flow, but also is there scarring, what is the diameter? So in her case, on the right side, you could see that her external iliac vein was 12 to 14 millimeters, that's normal. But on the left side, it is only 5 millimeters. So you can say it's open, but it's definitely not normal. We did an MRI, and we did indeed see that there were collaterals or pelvic veins, but you could also see that there is scarring in her iliac and common iliac vein. And you can see here very nicely her palmar vein, and the scarring in her femoral vein and popliteal vein just continues downwards into her leg. And you can see on this image also that she has quite a big GSV. So my diagnosis for her is that she has post-thrombotic syndrome, and that her palmar vein is a collateral, that her intra-abdominal veins could probably be collaterals too, and that her GSV is also a collateral. Now, that last point can sometimes be difficult. So is the superficial collateral or not? And I think that is, for this presentation, the main interesting point, and also sometimes the problem, because you have to really identify that. Otherwise, you will never be sure whether or not you can treat it. So do you leave it intact? Is it important for drainage or not? And I think duplex ultrasound is well, at least you start with that. But experience is key. So it can be difficult to see, is this reflux or is this a collateral? So what you could also do is do a venography with several runs, and you could use a tourniquet and try to close off the GSV and see what happens. In case there is severe reflux, but it's also collateral, then the question is, how much drainage does this GSV really provide? So is it really helping the outflow or not? So here you can see an example. This is not this patient, it's another patient, but you can see the superficial system and the deep system is well, it's really small and there's hardly any blood going through. And then here there is a tourniquet on, and then you can see that there is a little bit more blood going through the deep system, but it's still not much. So in this case, I would say that the superficial venous system is an important system for drainage out of the leg. So in our case, we just go back to her. Her GSV is a collateral. It was not refluxing, it was very big, and it was very important for her to drain her leg. So in this case, I would say do not treat the GSV. Please don't close it off, don't ablate it, but leave it intact. But what if the GSV was insufficient? So what if it was maybe a collateral also, but it was also very insufficient? And we're going to do a poll question here. So would you ablate this GSV then or not? And if you would you then do that first, or would you fix the obstruction higher up first? So what would be your strategy? And I will come back to this later and see what the audience thinks. So in this case, she also has pain in her abdomen, and this could definitely be caused by all the collaterals in her abdomen. So that for me can be, in terms of strategy, something that I take into account, because in this image, you can see a patient that has, it's not her, another patient, but you can see a lot of collaterals in her abdomen. And if you treat that with a stent, you see that those collaterals are, well, they're not really gone, but the blood is not going through there anymore. So that can help with her abdominal pain. In case of severe PTS, so if we're talking about, what are you going to do first? Are you going to treat superficial first or deep first? Then keep in mind that the obstruction might have a higher effect than the superficial reflux. So sometimes I treat the obstruction first, specifically like in her case, she has an ulcer, she has really severe PTS. But what do I take into consideration? I take into consideration the difficulty and the expected success of putting in, for example, a venous stent, patient characteristic like age and comorbidity, because it's still not, it's not open surgery, but it's, I think, a bigger intervention than treating superficial reflux. I take into consideration anticoagulation. Is it possible in this person or not? And is the patient going to be mobile or not? These are all things I'm going to take into consideration to take, to try and answer the question of what to do first. Let's see if we have the results from the poll back in this patient. If she also had a GSV which was insufficient, then well, it's sort of 30% all the way, but so people say ablate it, and then so only 30% say that. So most people say don't ablate it, because I think maybe because they think it is also collateral, so we need to save it. And then what do we do first, obstruction or the GSV? That's 35% says treat the obstruction first, and 38% treat the GSV first. I think Dr. Murphy, she will also talk about this. So let's go on. Are there guidelines on how to continue when you have a patient that has both deep and superficial problems? The ESVS guidelines, where Dr. Wilton already talked about, is a clinical practice guideline document, and they talk about this topic in one of their chapters. So you have a lot of different types of combinations, right? So you can have combined reflux, both in deep and the superficial system. And in that case, you can actually always treat the superficial. This paper that was published in a European journal looked specifically at patients that had both superficial and deep venous problems. And they found that if specifically when there's combined superficial reflux and segmental deep venous reflux, that if you treat superficial, that actually very often corrects the deep reflux in almost 50%. And that is also associated with increased ulcer healing in 77% of the limbs at 1 year. The SCAR study also showed, that's a very big study in RCT of over 500 venous ulcer patients. They were randomized into compression alone versus compression and superficial venous surgery. And also here it was found that even though there was in 25% there was a mixed superficial and deep reflux, that if you would treat the superficial system together with compression therapy, that had a significant good effect on ulcer recurrence, so to prevent ulcer recurrence, of course. So in the guidelines, there is an overview that helps you with the problem if a patient comes to you that has combined superficial reflux and deep obstruction. What is specified there is that you can either treat the obstruction or the superficial reflux, whichever one you want to treat first. And again, here it is very important to know if the superficial reflux, if there is really no collateral function at all. And the recommendation is that in patients with chronic venous disease caused by combined superficial and deep venous incompetence, treatment of incompetent superficial veins should be considered. It's a 2A/C recommendation. So when not to treat the superficial venous system, take home messages. The presence of deep pathology does not mean never treat superficial pathology. And I think a lot of people think that that's still what it means, but that's not the case. It can definitely mean that. If there's reflux, then treat superficial reflux, that's fine. Will it help? That also depends on the amount of reflux in a deep system. Is it only segmental or all the way down? But in case of obstruction, then the key thing is to determine if the superficial vein is a collateral or not. If it's not a collateral, you can ablate it, that's fine. If it is a collateral, then please do not ablate it because you will make things worse. And if there is a collateral and there is severe reflux, then that's up for debate. I think if there's severe reflux, then you can ablate. But again, you have to be really sure that there is no collateral function left anymore. When in doubt, I think that's also very important. Just ask for help. Have another colleague see and try to determine whether or not it's collateral, whether or not you can ablate it. And also think that a collateral vein can cause symptoms. So like in her case, her collaterals in her abdomen are causing her problems, but that does not mean that you need to ablate all the collaterals. That means that you need to find a solution to perform a procedure that will diminish the collaterals. And in that way, you will help her from her symptoms without doing any harm and making things worse. So with that, I'd like to conclude my presentation, and I'm going to give the floor to Dr. Murphy, and she is going to talk about when we can actually treat the superficial system and how this can be very effective actually and help a patient.
Excellent. Thank you so much. Yeah, this is a really important topic, and so much of it, as you pointed out, is judgment and knowing what to do first, when to do both. We're going to talk about a case and how we made that decision in this patient. Here is the patient. So 65-year-old male. He had an extensive history of left lower extremity DVT, iliofem pop, and he had a coincident PD quite a while before he presented to us back in 2006. And he presented about a decade later, as many of these patients do, not knowing the options, using compression. He had lifestyle-limiting leg pain and swelling. He had significant disease with varicose veins, hyperpigmentation, skin thickening. He had ulcerations both on his medial and lateral leg, which I'll show you in just a moment. He was CEP6. Oops, wrong button there. His diagnostics. So when you come up with a patient who has disease that seems out of proportion, and again, I'll show you his ulcers in a moment, to superficial disease that you would you would be surprised. The workup should include evaluation of the deep system at the start, so you know what you're dealing with. And then only then, when you have all the information, can you really make a true judgment about what to treat first. This patient had a superficial reflux on his reflux study in his greater saphenous vein and his small saphenous vein. And he had large varices that surrounded the wound coming off of these vessels, which is important, showing that it's contributing to those wounds. He also had significant valve damage. And like we had said in one of the prior talks here, you know, sometimes treating that superficial disease can reverse some of that reflux. Certainly that's true in the common femoral vein, usually not so much in the femoral and pop. And this is axial reflux with all of his deep valves out. He also had non-occlusive scarring in his left femoral and popliteal veins, but his inflow was open, including his profunda. He had a CT which showed some moderate iliac vein stenosis on that left side with kind of an ectatic vessel, and not occluded, not dramatic, but definitely affected by the prior DVT. So we decided first when evaluating this patient, because he had veins directly feeding that wound, he had significant reflux, fairly large superficial veins, and not terribly occlusive iliacs, to try treating his superficial reflux first. The advantage of this is it's the least invasive. It leaves no permanent implants. And in this case, the reflux seemed more severe, so more bang for our buck. Also, if we decided to treat with a stent later, this would already be treated, including all those large varices, meaning that we wouldn't have to hold his anticoagulation if we were having any trouble with his stent. So we planned for GSV, SSV ablation with concomitant phlebectomy for his large varices, and then we brought him back for ulcer bed sclerotherapy. Now here we had a really good result, right? So here's his wounds to start with, and you can tell that he's been having good wound care. He had these wounds present for several years, yet they're, you know, quite healthy wound beds, and he really did try to take care of them and did participate in wound care and compression. After his superficial procedures with continued wound care, he healed up quite nicely on both sides. His pain improved certainly from his, that he had associated with his open wounds. But what you notice is that his Ballantyne and his VCS is still significant. He was still having significant leg swelling without his compression. He was still having significant pain and claudication associated with that. Also, yes, his skin changes are markedly improved, but he still had fairly thick skin. You can see it's not really weeping anymore. It's pretty closed, but he has a scab there. It's kind of tenuous. And this is about 6 months after treatment. And he pretty much had stalled out at this point. A lot of doctors, if they're not familiar with looking for deep disease or treating it, would probably stop at this point. Certainly he's in a better spot. Certainly he has better wounds, but we can do better for the patient than just stop there. So we did evaluate him and sign him up for venogram and IVUS with a possible plan to stent, depending on our findings. What we saw is not the most dramatic presentation for patients that I treat, but he has an ectatic vessel, which just doesn't look very uniform. It shows that there's evidence of scarring, which is what we had seen prior. On his IVUS, we get a little bit more information. What we see is, again, this ectatic is kind of some intermittent scarring in the vessel. He has some, scarring towards the top. We can see the area. It's a real small print here, but it's about 100. You go just a little bit below that, and the diameter here, I think, is reading about 5. On the distal aspect of the common iliac vessel, he's now, up to, it's hard to see on the screen here, it's so small, up to a diameter of around 15 and an area of around 200. When you go into the top of the EIV just below that, he kind of scarred down a little bit more again. He's not terrible. His area is in the 140s, but his min diameter is about 8. When you go down a little bit lower, it opens back up. So now he's closer to around 200 again. Go back into the common femoral, and now you're around 100 with an average diameter of 9. Not terrible down in that common femoral, and he did have good inflow. Because of the degree of his symptoms and pain, we did decide to stent him. And when you're doing that, you have to pay attention to the details in order to get the right result. If you just toss a stent in on the top of this vein, especially noting that he had some segmental narrowing in his EIV and common femoral as well as some thickening in the vessel, you're not going to get the improvement that you would if you treat the whole disease. In veins, length of disease matters too, because that affects the pressure in a low pressure system. So you want to make sure you're treating the entire disease if you're expecting to get a nice result. When you're picking your diameter, you want to make sure you're oversizing slightly within a couple millimeters, although you want to avoid massive oversizing with nitinol because you can have pretty significant groin or back pain if you oversize. On the next image, you can see you pre-dilate always to the stent size. This does the work. The stent doesn't do the work in breaking up the scar tissue. It does the work of holding open that vein that you've fixed with that balloon. You want to profile afterwards with your balloon to the size of stent as well, to nominal pressure. This is important for nitinol as it helps it reach its maximal strength, which can then stay at it, kind of it loads it maximally. Without that post-dilatory step, that nitinol can remain a little bit weaker, which may or may not matter depending on the patient. So it's best to always post-dilate those to size. Here you see the completion imaging. His pre-venogram, again, looking a little bit ectatic. His post looking uniform and smooth with no hang-up of the dye. His post-op care, all these patients get Toradol once in PACU. I tend to admit most of these for overnight observation. It's kind of plus minus depending on your protocol and your institution. If they stay, they get every 8-hour Toradol, or if they go home, they get NSAIDs for 24 hours. I treat all the patients, particularly the post-thrombotic, with at least 2 weeks of Lovenox, and followed with oral anticoagulation or aspirin. I hear people talk about how long to anticoagulate the post-thrombotic patients. With a stent in place and post-thrombotic disease, unless you truly have zero inflow issues, my opinion is to do it indefinitely. The majority of patients that have problems with their stent are due to inflow, and unless that's perfectly clear with no other risk factors, it's not worth risking your stent, which can be very difficult to open. I do frequent stent checks to help maintain these and continued compression and conservative management. So here are his results. And again, it's fairly dramatic at every step. So from just treating superficial, we can almost, if we didn't know better, hang our hat on how much better he is here. But paying attention to the patient and his continued symptoms, in addition to the presence of deep reflux, which we can't really treat well yet, we now have gotten him significantly better with continued skin changes beyond where we were and continued improvement in his pain, swelling, and daily life. So remember to evaluate your patients comprehensively, to look at and treat both systems. Don't rest your hat on, we made him better, if he's not better enough, because we can get that patient many more comfortable years by looking at everything. You don't have to treat everything, but you got to at least recognize it or think about it so that you can partner with somebody if you don't treat all of it. So consider both symptoms. Also consider other factors that lead to venous hypertension. So there's patients who have obesity issues that they're not going to get as better as they should if we don't address the weight gain. Patients who have calcium channel blockers as a medication, maybe trials off of this or combining them with a diuretic. Patients who have all sorts of things, sleep apnea that's not treated. Thinking of all these things and working with the primary care can help your patient to have a better result. Maximize everything you can. And just briefly, kind of a summary slide for these patients. You get all the information from the first part, because that way you can tell, is this a collateral? Is this a occluded vein, like the patient where I wrote deep first here? The patient that we presented in the last case. If it's near occluded or you have collaterals off that GSV, that's not where you want to be. You want to treat that iliac first. If you have a patient who has severe superficial disease feeding a little wound like this in an area straight from the saphenous vein, you're going to want to treat that first. That patient may not need a stent. And patients who have all of these medical issues, heart failure, decreased calf mobility, obesity, things that are completely contributing to the wound. Remember, you can get a wound from a BMI of 50. That's not a vein problem. Even if you treat their vein disease, their ulcer may not heal. So you need to address those components. And in my opinion, if it's like this patient on the bottom with all of these medical issues contributing and only small venous issues, it's really not worth addressing with a stent and permanent implants until you're willing to have buy-in for all the other issues that are contributing more significantly. Okay, thank you.
Wow, thank you very much. That was a very nice presentation as well, and I think a very good overview of patients that can definitely come to your outpatient clinic, and it can be difficult. I think it can be confusing for patients or for physicians what to do, how to continue, and what to treat first. And when I was a resident, I was always thought that if there's problems in a deep system, that I could never touch the superficial system. So I think a lot of doctors are being trained that way, and I think it's good that we have a discussion on this and try to change, I hope, the physicians' minds. We have a lot of nice questions that have been sent in, and let's start with the first question that was sent in. And the question was, how can we put these updates in the guidelines into our daily practice in terms of follow-up and ongoing management? Maybe Dr. Wilton, you can address a little bit or say something about that.
Yeah, sure. So, I mean, I think the guidelines are obviously they're guidelines. They are important. They have helped us to make decisions with regard to how we treat certainly the superficial venous incompetence. So with trying to treat the endovenous thermal ablation as the first technique to try, obviously ultrasound guided foam if the vein is very small, and then listing the other types of non-thermal endovenous ablation techniques that can be used. So, I mean, in the UK, we have our NICE guidelines as well, which actually sort of are exactly the same, suggesting thermal ablation first. And if you can't do that, then ultrasound guided foam or other techniques, and not forgetting, obviously, surgery, if appropriate, in certain patient groups. So I think it's important to remember all the different types, but thermal ablation first if possible.
And the next question was that is there recommended treatment options for perforator incompetence together with superficial reflux? Would treating just the superficial system first and observing be a reasonable approach? Dr. Murphy, do you want to comment? What do you do with perforator incompetence?
Yeah, so I wonder if that might differ a little bit depending on where you are and what your coverage issues are and what technology you have. But generally, perforators here are covered after you treat the majority of superficial disease. Some of those, and make sure that they're actually incompetent, because sometimes they'll identify a large perforator associated with wounds, but it's actually a re-entry perforator. So you want to make sure that it's big enough that it's contributing, that you've treated the majority of other disease. I'm not opposed if you have a large perforator ablating it at the same time, if your coverage allows you to, if you think that it's contributing directly to a wound or subcutaneous or skin changes. Typically, I treat superficial. If I think a perforator is still contributing, then I'll treat that separately, because most of them don't need to be treated. You don't want to be chasing them. I do think that we should treat the subalcer plexus. So if you are treating like a saphenous vein and somebody has a wound, injecting some of those veins directly under the ulcer may help heal the ulcer and close small perforators, preventing you from needing to ablate them later.
Yeah, I do the same thing. Do you do the same thing too, Dr. Wilton?
Yeah, no, absolutely. Completely agree.
Yeah. Then there's a question about, I think, my patient. And the question was that my patient is using rivaroxaban 10 milligrams. Won't she be getting 20? Shouldn't she be getting 20 milligrams instead? I'm not sure for atrial fibrillation, to be honest, if that should be 20, but for deep venous thrombosis, if a patient has deep venous thrombosis and she is being put on continuous or lifelong anticoagulation, then I tend to go down to 10 milligrams after 3 to 6 months. And we'll always discuss it with the hematologist. I don't make the decision by myself, because there is another question about this, and that is, what is the importance of implementing a multidisciplinary approach in the treatment of combined deep and superficial venous disease? And I really like that question, because I'm all for a multidisciplinary approach. specifically when we're talking about, for example, anticoagulation. And also I like the case a lot from you, Dr. Murphy, where you also said that it's so important to think about, for example, that you're going to anticoagulate the patient after a stent. So maybe it's wise to do specific treatments first. Just always think ahead and how you're going to treat this patient, and all the decisions you're going to make will influence what's following next. So I agree, multidisciplinary team all the way, specifically when you're treating the deep system. I don't know how it's organized over in your centers. Dr. Wilton?
Yeah, no, I mean, I completely agree. So I mean, I think for straightforward superficial venous incompetence, obviously you don't need any MDT approach, but for us, we have a dedicated venous multidisciplinary team that meets regularly, and all the more complex superficial venous cases, as well as all the deep outflow obstruction cases, get discussed there with hematology present, myself as a vascular surgeon, and interventional radiology.
Yeah, Dr.
Yeah,
Murphy, the same. That's
yeah, that's ideal. I work with my hematologist very closely in the wound care center as well.
Yeah. And do you both go down on lowering the dose of the DOACs when patients need to be on lifelong anticoagulation, depending, of course, on the type of DOAC?
I do a case-by-case basis, depending on how bad their inflow is and their overall picture, their clotting disease, their ambulation status. But yes, I do that quite frequently.
Yeah. So again, that's a decision usually that you need to make together with a hematologist, and it's all patient tailored. And then there's a question about what are the potential complications of untreated pelvic venous disease? Maybe I can answer because it came up in my presentation. I'm not sure if there's so many complications, but first of all, it can be really painful for patients. So if there's a lot of pelvic veins, then specifically around menstrual cycles, women can be in a lot of pain. And they can have problems, also with their bladder, which can be really irritated. I think the most important thing is it's usually not looked after. So patients are presenting with abdominal pain and they go through all these different specialties like the gynecologist and the doctor that's more into treating bowel problems, and no one knows what the woman in question have, and it's just often overlooked. And I think it can be really good for the patient to at least be recognized and be diagnosed, and then try to fix it. What are your thoughts, Dr. Wilton?
Yeah, no, I agree. I think I don't think there's any particular complications, are there? But I agree. They're often overlooked, and they often see the wrong people actually before they get to you.
Yeah. And then there was a question: Did we change our practice after data from the ESCAR study? Yeah. So, like I said, I don't know how you were being raised as surgeons, but I was really raised and saying you never treat the superficial system when there is an obstruction or reflux, and now I'm completely the other way around. So and that's not only from the ESCAR study, that's also just from clinical practice and seeing how these patients can be treated so well when you treat the superficial system, for example. Dr. Murphy.
Yeah, I completely agree with you.
Yeah. And there is a question on biomarkers. Do either one of you use specific biomarkers or imaging techniques that can add an early diagnosis and risk stratification of chronic venous ulcer patients? I don't do that, no biomarkers, but imaging, yes. If there's an ulcer patient, I would always do an ultrasound of the abdomen, but I do all my ultrasounds myself, and it's so easy to just look higher up, so I do an abdominal ultrasound. But biomarkers, I do not specifically. Do either one of you do that? No. And imaging techniques. So, in which patients, Dr. Wilton, would you do an imaging of the abdominal deep veins?
Yeah, so I mean, again, ulcer patients for sure, I would look for venous outflow obstruction with cross-sectional imaging. And I think from the history, so if you've got history of DVT or anything that makes you slightly suspicious, so I don't know, radiotherapy or something to the pelvis for other reasons, etc., where there may be an outflow issue, then I would do cross-sectional imaging as well as standard sort of lower limb venous duplex scan.
Yeah. Anything to add, Dr. Murphy?
Yeah, I would just add skin changes or edema that's out of proportion to superficial disease. So if you have full calf edema, usually a superficial disease can only give you ankle edema. If you have circumferential skin changes, something that just doesn't match what you found on your superficial workup.
Yeah. Very young patients that already come with a lot of superficial varicose veins, or they don't really react well to treatment, I would do it too. And yeah, I agree with the history, because the patients maybe have like central lines, or they were how you say that, they were born too early, and then maybe they had lines in that period of time. So I always ask for that too. That can be triggers for me to look higher up. What are the unique risk factors that should be considered when treating superficial and deep venous disease? Good question. What are unique risk factors? Yeah, Dr. Murphy, any thoughts?
Risk factors for the patient when I'm considering whether to treat the deep system would be patient's mobility level, patient's weight, their clotting disorders, particularly anticardiolipin, or a lupus anticoagulant patient. What else? Those are the primary ones that I'm looking at, and then I'm addressing their inflow. And, you know, there's high risk or low risk patients based on their inflow status. And I guess also the other one would be compliance. Patients who are, you know, if it's a huge red flag to me if they're not routinely compliant or with either medication or office visits.
Yeah, I agree. And another nice question is, what is your opinion on treating the both superficial and deep pathology in the same setting instead of staging that? I've never done that, but why? Can you think of a scenario where you would?
Yeah, so I'm aware of some practices that have done that. And typically it's practices that are doing their superficial cases in a cath lab OBL setting. I do mine in the office versus, you know, the cath lab procedures, stenting is done in the hospital. But really, you know, in my opinion, the vast majority should be done separately with an assessment in between. I think the only time to do that is if for some reason, I've done it a couple of times when I had a patient who doesn't tolerate needles or has a very low pain threshold or is terrified of getting the superficial done, and it's quite obvious in an advanced patient that needs, you know, like if you had a occluded iliac and a GSV going down to a wound, sure. But I think it's a very rare circumstance that you should do that without evaluating in between. I also think in the US, it's a setup for litigation if you're doing that in patients without a really specific reason to do it.
Yeah, and I agree. I do it in the outpatient clinic when the superficial treatment, and the deep, of course not. So also, I think if you're occluding veins, I don't know. I mean, there's always a small risk of DVT. So you're doing something, you make a patient a little bit more hypercoagulable, I think, and then you put in a stent, and then the last thing you want is patient in that sort of state. So yeah, for me, it would be a little bit contradictory or something. It doesn't feel right to do it at the same time. I don't know, Dr. Wilton, did you ever do that at the same time?
No, I haven't, and I completely agree. And I think, you know, you could treat if the superficial was more the culprit, you may end up treating that. And if you've just got a sort of mild to moderate outflow obstruction or obstructing lesion, you may not need to treat that at all because the symptoms get better and you don't need to do any more. So I think Erin's point about you know, seeing them in between is definitely prudent.
Yeah. Okay, final two questions. When is surgical intervention such as deep venous valve repair bypass procedure warranted for the management of deep venous reflux? And how do you select the most appropriate technique? Good question. I've never done it, so I think it's for very selected cases. But any of you have any ideas on this or an experience?
I'm not a fan of the open valve surgeries. We'll see how some of the endo techniques go, but seeing some of those patients long-term in a practice that did a lot of them way back in the day, they often occlude over time, and they're very difficult occlusions to deal with because it's now a surgical scarred occlusion. Also, the benefits don't seem as great as stenting. Bypasses traditionally have lower patency. We've had some luck here in salvage cases, but I think there's very few indications for it. And I would do it as a salvage of a stent failure only and in an advanced center. Our best luck with open surgeries is with endophlebectomy. And really the only indication for that is having severe inflow disease at the femoral profunda confluence. It has to be at that location where you can get to it, particularly if it's in the first centimeter or two of the profunda, because it's hard to keep a stent open. But you can stent the rest of the outflow. But if you have inflow disease below that or no open profunda femoral, then it's not even a candidate for open or endo.
Mm-hmm. Yeah. And then final question. In double pathology, deep vein obstruction and superficial vein insufficiency, what is the most effective way to know if the superficial system is acting as a collateral or not? A very important question. And yeah, I'm curious about actually also what you think. But I think it's difficult if you're not that experienced, probably. So duplex ultrasound is my go-to, and I think I usually can tell from that. Like I said in my presentation, you can do phenography and you can try to close off the superficial system and see how the drainage goes. But yeah, if you do a duplex ultrasound, you see sort of continuous flow, you see a very big vein, but you don't really see reflux. And maybe it's the combination of the fact that you don't see, and you see the obstruction, and then you, for example, in her case, you could actually see from the GSV, it goes into the palmar vein and then goes to the other side. And that to me is like, this is her drainage overlag. This is her collateral function. But I don't know, how do you decide, Dr. Wilton?
No, again, I mean, I would do the same as you. So do a duplex ultrasound and then by a skilled, either yourself or another skilled person. Again, we would discuss it in a venous MDT and potentially do venograms if you're really not sure as well, to try and ascertain which one.
Mm-hmm. So I would add, I agree with both of you, and I would add that you can get, I don't know if you do cross-sectional imaging in your patients that you are looking at for deep disease before intervention, but you can nicely trace the GSV to GSV collateral, and it comes off the very proximal or cranial portion of the GSV. I have ablated the GSV in a guy who refused to have me open above, but he kept getting wounds. And I ablated that GSV at a little cautiously, and it did close that collateral, but that collateral reopened within about a week, and the GSV remained closed beyond it. So you can treat those patients, but unless you have a situation like I did where they refuse to let you address it, I would always address the occlusion first.
Wait. Yeah, sorry, 2 more questions came in. I don't know till what if we can still address it, but as long as we're not being cut off, then I will. So in your opinion and experience, how often are patients placed on anticoagulation for superficial vein thrombosis rather than conservative management, given the majority of patients tend to be asymptomatic? Good question, Dr. Wilton.
Well, I mean, we only see the patients that are symptomatic, really, because they're the ones that are being scanned because they've got symptoms. So in those cases, we tend to follow various protocols, of which I put up the slide. So if they're within 3 centimeters of the deep system, then we would fully anticoagulate. There are various guidelines depending on where you work as to how long the segment is, whether it's above the knee, GSV, etc., as to whether you would sort of partially anticoagulate or etc. So I think you'd follow local guidelines with regard to that. But I think, I mean, yes, you often have a duplex scan in a patient. Perhaps you're about to do superficial venous incompetence, and you can see that they've clearly had there's some scarring within the superficial veins, and they have no history of previous superficial vein thrombosis, but I think, you know, the time has passed at that point. So you'd only treat in the acute phase.
Yeah, I think a lot of patients are not treated by anticoagulation, but that's because all those patients are over at the GPs. So we were writing a paper for a Dutch journal together with a GP. And yeah, we were promoting, you know, do a duplex ultrasound to see the risk of the patient. Should we put them on anticoagulation or not? And then the GP was like, but I see so many superficial vein thrombosis, and I'm not going to do, you know, a duplex ultrasound all the time. It's in a varicose vein. It's not, you know, I don't need to do that. So I think it happens a lot of the time, but that is not the patients that we see, because like you said, those patients are referred to us because they're symptomatic, and then you do the duplex ultrasound and then you follow the guidelines. So yeah. And then the last question. Hi, Marie, Emma, and Erin. Do any of you three use or promote prophylactic herbal treatments like nattokinase or fruit flow on top of compression stockings for high-risk patients with venous disease who fly long-haul or ultra-long-haul flights? I do not. But yeah, I mean, regarding anticoagulation, for example, on long flights is a topic of debate in our department, because hematologist says if a patient is not on anticoagulation anymore but had a DVT prior, then they tend to say you don't need to give that. But the patient is very anxious, so they like to take something. So I usually do prescribe something. So I choose between prescribing anticoagulation for a certain period and the compression stockings, and I advise them to walk every hour and drink enough, but no herbal treatments. Did any of you two ever prescribe that?
I think there's some data. Even Monica Gavitsky just did a presentation at the IUP too, and I think there's some data. It's older, and I think perhaps it's something we should be looking at to optimize some of our patients. Things like horse chestnut, and there's a good number of others. I think that's an area that is a little less explored and probably has some validity to it. It's just hard to navigate. So I haven't started actively prescribing it, but I feel that we maybe should look into it.
Yeah. Dr. Wilton, this is the final question. Any final remarks?
No, I don't personally prescribe it, but I agree, there is things we can look into to see whether there are benefits.
Yeah. Okay, so then I hope all of your questions are answered. Yeah, time is up for us, so we have to stop the session. I'd like to thank the faculty very much, Dr. Murphy and Dr. Wilton, for joining me today, and especially all the viewers that have been sending in all these wonderful questions and made it so interactive. Thank you very much for that. I hope it was up to your expectations. I hope you know what to do now when a patient comes in your office with combined superficial and deep problems. I'd like to thank everyone for watching, and for Radcliffe for organizing this wonderful webinar. Have a very nice day.